Mitt namn är Anders Fasth och jag är seniorprofessor i ämnet pediatrisk immunologi. Det betyder barns immunologiska sjukdomar. Det kan variera sådant från sådant som inte kan försvara sig mot infektioner, men också där immunsystemet inte fungerar som det ska utan ställer till det i kroppen. Till exempel kan ge ledgångsreumatism eller inflammation på andra ställen i kroppen. Och jag har kommit i kontakt med barnen med PANS eller PANDAS just i min egenskap av immunolog.
Anders Fasth, du har ju jobbat då med patienter under väldigt lång tid, 50 år. Och för första gången träffade på PANS runt 8 år sedan. Var det någonting som överraskade dig i symptombild hos de här patienterna när du först träffade dem?
Egentligen inte mer än det hastiga insjuknandet. Det här att när man träffade på så kunde föräldrarna säga på dagen, ja i vissa fall till och med nästan timmar när de blev sjuka.
Just det.
Men annars hade jag funderat kring inblandningen av immunsystemet på sjukdomar i nervsystemet sedan länge faktiskt. Jag tror faktiskt ända från mitten av 80-talet då jag uppmärksammades av vår dåvarande professor i neurologi på området, och han faktiskt skickade mig på en konferens om neuroimmunologi.
Så för dig var det inte främmande att infektioner kunde skapa den här typen av felriktat immunförsvar och därmed ge svåra psykiatriska symptom?
Nej, egentligen inte. Det var det inte, utan jag blev snarare nyfiken och ville veta mera kring det hela.
Och vad tror du har varit utmaningen? För alla har ju inte accepterat det faktum att det här infektioner eller andra saker då kan innebära ett immunförsvar som reagerar annorlunda. Vad tror du är hindret att folk inte vill ta till sig den kunskapen?
Jag tror att en del är att man jämför med vissa andra neuroimmunologiska sjukdomar och där vi har en markör. Vi kan hitta en autoantikropp till exempel. Och det har ju hittills man inte lyckats vid PANS-PANDAS. Och jag tror att det är en stor anledning till att många barnneurologer och även barnpsykiater inte vill acceptera diagnosen.
Så vi behöver alltså fler forskare som gör ett skickligt arbete inom det här fältet och mer resurser. Ser du att det alltid finns en autoimmun aspekt i det här, eller tror du att det kan variera utifrån individ?
Eftersom vi inte vet orsaken idag så är det väl rimligt att se att det varierar. Man har ju dragit mycket slutsatserna från PANDAS, alltså att streptokocker skulle vara orsaken, och likheten med Sydenhams korea med reumatisk feber. Och det är väl rimligt som en modell. Men alla andra infektioner, ja där behöver vi mera och en bättre förklaring hur de skulle kunna trigga och utlösa det här typiska insjuknandet.
Vem tror du har bäst verktygslåda? Vilken profession eller vilka professioner behöver samverka till de här patienterna?
Jag tror inte att det är en profession. Jag tror att det handlar om dels de olika kliniska professionerna, barnpsykiatern, barnneurologen, immunologen samarbetar som något exempel. Men sen så skulle jag också gärna vilja se några djurmodeller över sjukdomen. Om man där kunde komma närmare förklaringen. Och då har vi ju basal forskning helt enkelt inom i neurologi och immunologi. Så får vi hoppas att vi förstår bättre.
Så, och fram tills dess att vi vet allt så behöver vi förhålla oss till den beprövade erfarenhet som vi just nu har. Och då behöver det professioner som bistår i de här fallen. Det är så jag tolkar det.
Och ha ett öppet sinne för att se patientens symptom och vad vi kan göra i dagens läge.
Hello, my name is Michael Daines. I'm a pediatric allergist immunologist. I'm the co-director of the Children's Post-Infectious Autoimmune Encephalopathies Center here at the University of Arizona. The Children's Post-Infectious Autoimmune Encephalopathy Center deals with children that are having post-infectious reactions that are impacting mood, movement, and behavior. These would include disorders such as PANS and PANDAS, which are part of this family of problems.
So you see that this is a big impact on the family and the siblings.
It's got a huge impact on the family and the siblings. It's like throwing a hand grenade into the middle of the dining room table. The children become very needy. They have tremendous anxiety and OCD that impacts everything that the family is trying to do. And even when medically we treat the inflammation and get them on the road to being better, there are still steps that need to be taken with therapy to try to help them understand what they've gone through, and then teaching the parents how to parent these now somewhat damaged children until they can get completely better.
Have you developed your own strategies for this patient group?
Yeah, so I think the problem is if you approach this purely from a psychiatric or behavioral standpoint and don't treat the medical part, you're dooming yourself to failure because they're still going to have that inflammation driving things. They're still going to have the same problem that their innate biology is causing them to have this. But going the other direction, if you only treat the biology and ignore the psychological and behavioral impacts that it has, you're never going to get the children back completely to where you want them to be. So we use a multidisciplinary team approach to try to get these children completely and comprehensively better.
Why do you think a lot of people, also in the profession you work, why people don't believe in the disease? Is it also that in your case, in your country?
So I think belief is something for religion, not for medicine. I think medicine needs to be based on data, and there's good data to support this. The Dr. Sweeto wrote up the first 50 case series in 1998, I believe, and had a very defined group of patients that had a matching set of symptoms that they showed up with. And so this is a clinical diagnosis, which means that there isn't a laboratory test or an X-ray or a biopsy or something that verifies it. It's based on a spectrum of clinical illness. And we have a lot of clinical diagnoses in medicine that we take care of. No one diagnoses bacterial otitis media, which is just an ear infection, because to do that, you would have to put a needle into their ear and aspirate the fluid out and culture it. Instead, when someone shows up with a fever and a red swollen eardrum and pain, you treat them with antibiotics. And this is the same kind of thing. We know what the clinical presentation is of children that have this. And so based on that clinical presentation, we try to treat them and get them better as quickly as we can.
What would you say is the dangerous part if you don't diagnose and treat these children? If they get ill and will be ill for a long time before they get help?
That's a good question. So there are the children that we see that we diagnose early and that we have that acute, very sudden onset of symptoms. Those are the ones that respond best to the anti-inflammatory treatment, and those are the ones that need less of the ongoing therapies because they don't have as much of a negative impact of the illness on their life and on their family. The children that have had this chronically, either because inflammation is no longer a part and you're actually dealing with damage to the brain, or because the psychological and behavioral changes have ingrained themselves into what the patient is, are much harder to treat and are much less likely to get a full recovery.
So there is a good hope for those kids who we take care of immediately, is what I'm hearing. And I also hear it's very important to do that so we don't have the full length of consequences.
Absolutely. early recognition and early diagnosis and early treatment are the most important things. And I'll be honest, the recognition is the hard part because uh, it isn't something that people think of off the first part of what they're doing. And so if you don't have people that are aware and are thinking about it, these kids will just end up in behavioral health or in psychiatry or in somewhere else where they don't get the biology treated that they need.
You also recently had Dr. Gillberg and his team visiting you.
Yes.
Can you please describe a little bit about it? We have also met them here today during this hearing. Yeah.
Yes. Well, it was wonderful to get a chance to meet them. My mother is Swedish and goes back every year, so it was nice to have a chance to talk to them. They're a wonderful group that I think are building a very good program. You have a very different water to swim in than I do, and I think there are going to be some unique challenges to building out a multidisciplinary clinical approach to take care of these children. But I also think it's a moral imperative to do it because if you don't, you're going to be dealing with these children as long-term psychiatric and behavioral problems, which is going to be far more expensive and far more traumatic on the child and far worse for the family than the early diagnosis and treatment would be for them.